Hello, this is Lynn Quincy, the Director of the Healthcare Value Hub, and I would like to welcome everyone who's joined us today on the phone and hopefully on the webinar to our topic, which is pushing the envelope, how state insurance regulators can use their authority to address healthcare affordability. We're going to go ahead and get started, and this is my picture if you're looking at the webinar in case you haven't met me before. Hello, but that's not the important thing. We have a few housekeeping items as we always do. First of all, thank you for joining us today. If you are not a speaker, your line has been muted until the question and answer period, but never fear, we allow a lot of time for Q&A. And if you have a pressing question while our speakers are speaking, please type it into chat so we don't lose track of it. This webinar is being recorded. We get a lot of requests from people who can't participate in our webinars. They want to listen after the fact. So if you are verbalizing your question later in the webinar, just keep in mind that we're going to record it and post it on our webinar. And finally, if you're having technical problems, perhaps you hear my voice but you're struggling with the webinar, you can call Tad Lee at 202-776-5126. And Commissioner, let me do the slides for now. Thank you. With that, let's go ahead and hear about what we're going to talk about today. I am going to provide a brief introduction to what rate review is, and we're then going to hear from two insurance commissioners, Commissioner Ganem from Rhode Island, followed by Commissioner Kreisler from Washington State. And let me give you a little preview of why we've invited them to speak with us today. The National Association of Insurance Commissioners has shown quite a bit of leadership, in particular this year's President, Julie McPeak from Tennessee, that has initiated a year-long initiative that's trying to find out or examine how regulators might better address the underlying cost of health care. In many instances, commissioners currently might take that as a given, something they can't affect, but we're going to look today at how they might be able to affect. And what we're specifically going to address today is the ability of rate review to perhaps get under the hood and looking at that underlying cost of health care. Some of you listening today may not be familiar with that term. Rate review is an annual opportunity to dispassionately examine the assumptions and cost factors that go into a premium rate. In most states, how rate review is conducted varies from state to state, but in many states, what regulators, and they might bring in other experts, will often do is look at the proposed rate increase and see if they seem to be reasonable based on cost assumptions and other evidence. You're going to hear more about this. Often, but not always, the rate filing includes a justification that explains the reasons why a health plan is seeking to increase their rate. You may not be familiar with the term rate. A rate is very similar to the premium but different. Health plans will file something called a rate, and it becomes a premium by applying rating factors to the extent it's allowed within a state. Rating factors can be things like age, geography, tobacco use, the number of covered family members. So that's how rate is related to premium. So what does all this have to do with affordability? Well, when you scrutinize this filing, this rate justification, you can do things, first of all, by like identifying errors and double counting or inappropriate assumptions and or improper contributions to reserves or surplus. And all of those things can result in a lower rate for consumers. But what we're talking about today is actually going beyond those common ways of examining a rate and I'm calling it looking under the hood. Rather than taking assumptions about medical trend as a given, asking health plans to provide evidence of cost containment and quality improvement efforts. Again, as my final intro here, I do want to emphasize that what happens inside of states varies considerably. We still have a few states that are considered to not have an effective rate review process. Many states use a standard that might be characterized as excessive, inadequate, or unfairly discriminatory, which would not include the ability to look at cost containment or quality factors. But some regulators can do more. And with that, let's hear from these regulators. Oh, sorry, not with that. First of all, we often forget to say this at the end of the webinar. The Healthcare Value Hub, as always, has lots of resources to help you work on this issue, including a grid of states with expanded authority, a glossary of terms, and a primer on rate review. And those can all be found at our website. We'll put that link up again later. Now, with that, let me turn it over to Commissioner Ganim from Rhode Island, who's going to tell us about their very unique approach to the process of rate review. Commissioner?
Thank you. Thank you. And I want to very quickly get off of the page with my picture on it. I hope you all understand. And talk a little bit about leveraging rate review to drive system affordability. First, I have to preface my remarks by saying that I know that there are a number of other states who are doing very innovative.
Commissioner, I apologize for interrupting, but someone asked if you could speak up a bit or maybe move closer to the mic.
Okay, that's great. I will. Thank you. Thank you for that. The slides today are focusing on leveraging rate review to drive system affordability, and I wanted to acknowledge that many states are, in fact, engaged in looking at, very creatively at how they apply their authority in bringing costs down. I've been very impressed at the National Association of Insurance Commissioners with how many commissioners are very, very serious about healthcare costs and healthcare coverage in their states. So I think we're really...
And Commissioner, I apologize so much again. They're still struggling a little bit to hear you. Is there anything else, maybe turning up the volume on your phone or getting even closer? And this is the last time I'll interrupt, but anything they are asking for a little bit, making it easier to hear.
All right, I'm going to try without speakerphone, see if that works.
Oh, that's better. Thank you. Thank you.
Thank you. That should work better. I'm so sorry. So I'm using up all my time.
We'll give you extra.
Thank you. I just again wanted to acknowledge that other states are very aggressively also looking at healthcare cost containment, and the National Association of Insurance Commissioners has made it a priority, as you stated. And so in Rhode Island, we review commercial health insurance rates, and over the years, we have been able to see a decrease in what the insurers send in to us as to what they would like to see their insurance rates, their premiums, their average premium increases being. As you can see from this chart, the difference between what we have approved and what they have submitted has decreased over time. So unfortunately, we have a very small commercial market. We just have 220,000 enrollees. But since 2012, with that base of enrollees, our rate review, we've calculated, has actually saved $235.7 million. So the difference between what the insurers have asked for and what we've actually approved has amounted to that much money. It's pretty significant savings for the consumers. We think one of the reasons why this has tightened so much, and you can see particularly in 16 and 17, that one of the reasons is the level of scrutiny that we give just to the rates, just to the assumptions. But simultaneously what's going on is we're also holding the insurers responsible for carrying out some affordability standards and actually moving forward to bring costs down. And so I'll go into a little bit more detail about that. So originally, just as was said in many other states, Rhode Island was exactly the same. We were looking at rates back prior to 2005 from the perspective of, is it consistent with the public interest and the proper conduct of business? And from that perspective, of course, you're going to look at if the insurance company is going to stay in business, if these rates are actuarially appropriate, and you're going to look at consumer protections. If the consumers are going to get adequate coverage for the services they're seeking in exchange for what the proposed premium is. So there's nothing wrong, certainly, with taking this approach to insurance regulation. It's very sound and adequate. However, it didn't get us to the underlying costs that were causing the rates to go up every year. So what happened? We had a kind of a window of opportunity in 2005 that really changed the structure of health insurance regulation in Rhode Island. And I mentioned a window of opportunity because there were a number of things that came together at the same time. One was we had an individual, a very dynamic leader in the state who had been both an insurance regulator in the state and the attorney general in the state. And that individual was kind of in between jobs. He's now a U.S. Senator, and we're very proud of him. But at this point in time, he was in between jobs, and we were able to tap into his expertise to help us address some of the things that were being raised in our healthcare system. So one of the things being raised was that our providers were very upset with their relationships with the dominant insurer in the market and felt as though they were being mistreated. And it was more than just rate conversations, how much they were going to get paid for their services. It went beyond that into other forms of treatment and relationships. So they were looking for a place to go to be able to arbitrate or to be able to at least listen to what the concerns were. In addition to that, we had our major nonprofit health insurer at the time got caught up in some legal issues and some public relations issues relative to some ethical activities as well as probably spending elaborately for what you would expect a nonprofit to be doing. So that came together, those forces came together, and really was the impetus for the creation of a separate office just to look at health insurance. So extracting that from our overall look at insurance and regulation of insurance in our state. And number 4 here on the screen was really innovative, a creative, and bold addition to the role of an insurance office. And that is that we're not just looking at whether or not health insurers can stay in business, but we're looking to make sure that their policies improve our healthcare system, affordability, quality, and accessibility. So that's really where we get so much of our authority from that we're able to use. We also, at the same time, I think it's important to note, we had a Health Insurance Advisory Council created. That advisory council has been tremendously supportive of the work of the office. It is composed of business, consumer, and providers. And that group, taken together, we don't always agree 100% on everything, but they've really formed the grassroots support that is needed to continue to do what we're doing. So this is how we began. So when the office first started looking at how they could get to this affordability issue, they actually used rate review as the main focus. So the insurance company would submit what they thought were rates that they wanted to charge for the next year. The office would look at those and then would put certain conditions on them. And originally, the conditions were that they would increase their primary care spending, and we'll talk a little bit more about that on another slide, but without increasing premiums. So you'd ask yourself, why would we do that? So there was evidence at the time, and it continues to be strong evidence, that healthcare systems that spend more on primary care actually save in the long run when it comes to hospital care and to even the population health. We also said at the same time, you can't increase your premiums while you're doing this, but we want to invest in a medical home model. So it's not just primary care, but it's primary care that's truly focused on good health outcomes. And we were able to get Medicaid and the commercial insurers all to get together to move this forward. We also told them that they were prohibited from granting hospitals an annual contractual price increase that exceeded a certain cap. The cap started at CPI, urban CPI plus 2, and now it is at CPI plus 1%. That comes out to about 2.7% for last year. And that they must tie half of that rate increase each year to quality performance. So it's not just an automatic rate increase. So here's what happened with primary care. Again, without tying an increase to primary care in the premiums. From the beginning, as you can see, we started at about a 5.7% investment in primary care, and today we're looking at 11.4%. And this while this has been a struggle for the insurers, I think, to make certain that their investments have been made in the highest quality primary care, and we have simultaneously made certain that this investment has been given to primary care practices that are doing the things that we want to do to see better outcomes for patients. So things like having a care manager in their office and transforming their approach to their hours, for instance, being available longer hours and weekend hours. So if they meet these standards, these criteria, these practices are actually getting a bonus. They're getting a little bit of a supplement in their reimbursement rate from the insurers, and that accounts for much of this increased spending. And just a note, in 2015, which is the last year here on this slide, Blue Cross Blue Shield of Rhode Island, our largest carrier in the market, did a review, an analysis to see if they were actually getting a return on investment for the spending. And they concluded that for the transformed practices, for the medical home model practices, for every dollar they were investing, they were seeing a $2.5 return. So that makes us feel like we're going in the right direction. So after we were doing that through rate review, we actually decided that we should put this into regulation. So in Rhode Island, we've gone from this being incorporated as a condition that we look at in the rates and that we require every year to regulation that every insurer knows they must comply with annually. And we've added to it. So we've subsequently added a move toward alternative payment models. So we're asking insurers now to invest more and more each year on pulling money from fee-for-service and putting those dollars into value-based purchasing. So we're in the process of monitoring how the insurers are doing that. We give them some guidelines, and we're looking at how much they're actually spending on total cost of care or episodic care payments and accountable care entities. We also are looking at the percentage of lives in the commercial market that are attributed to these alternative payment models that have downside risk. So basically what downside risk is that if an insurance company gives a provider or an accountable care organization a certain amount of money for a patient, and that provider exceeds that money at the end of the year, the provider actually takes some of the loss. So that's downside risk, and we are attempting to move our system to really incentivize better quality, more volume, more value over volume. We're actually moving in that direction. And lastly, our insurers are prohibited from granting an annual contractual budget increase that exceeds the cap for these accountable care entities. So we're not only saying put more money, put a greater portion of your premium into this more accountable spending, we're also saying you can't increase that spending by more than a cap each year. So what have we learned in Rhode Island? We've learned, first of all, that it's hard to measure what you've learned. So we are in the process of trying to measure outcomes relative to the hospital cap, relative to the primary care spend particularly. But we've learned that as a regulator, you can actually play a significant role in promoting system affordability just by saying to the insurers, you need to do these things. And we've certainly had some good results trying that approach here in Rhode Island. What we found also, though, is that having that legislative mandate that we had, that it kind of expanded our role from just looking at insurers to looking at the healthcare system as a whole, that really did provide us with what we needed to promulgate the regulations to put out the word to the insurers that this is what our expectation is. We certainly did employ bold administrative interpretations of our existing statutory authority. And whether or not other states have the environment in which they can do that, I'm not certain. I do believe that having our Health Insurance Advisory Council, having the providers and the consumers and the folks in the business community around that table really did support us in moving forward with this bold interpretation. And we work very collaboratively with our insurers, our providers, and our consumers, and we found that is critical. So when we are looking every year at how we're doing relative to these measures, whether or not we should change them, what our goals are each year that we should be meeting. That is done in a large group. There are representatives of all of these different bodies there, and it is a consensus-building activity, all toward a goal, but yet we build on the consensus. And the one last piece that's not here that I wanted to mention is that we've learned that we need to align with Medicaid. So that's probably comes to everybody's mind is that Medicaid actually has more lives than we are responsible for in the commercial market here in our state. And so if we line up our priorities with Medicaid, we are so much more impactful. So our primary care initiative is in line with Medicaid, as well as our accountable care organization efforts. And we are seeing much more influence on the system by lining up with our folks at the Medicaid office. And thank you. That's it.
That was wonderful. Thank you so much. All right, I'm going to move on to our next and final speaker before Q&A, Commissioner Kreisler from the state of Washington, who's going to talk about a fairly different type of authority. Commissioner Kreisler? All right, we're not hearing you yet. You might still be muted. Commissioner Kreisler? Well, we had Commissioner Kreisler on the line earlier, and I suspect he will be back. So maybe one of the Hub staff could reach out to the folks out in Washington, and in the meantime, we could ask Commissioner Ganem to answer a few questions. And Hub staff who's reaching out to the Commissioner, just tell him to interrupt when he's back on the line. So we have, is that all right with you, Commissioner Ganem?
Yes,
we'll ask a few questions of you, and hopefully Commissioner Kreisler will join us when he can. So first, we have Andrea Johnson, who I see has raised her hand. Andrea, if you would like to verbally ask a question, you can hit *6 to unmute. Oh, and actually, Commissioner Kreisler, if you didn't dial in on the speaker line, you can hit *6 to unmute. Maybe that's the problem.
That's it.
All right. Thank you. Andrea, don't ask your question right now. Sorry. Anyway, we got to the bottom of it. We are so pleased to have you with us. Please tell us what's going on in Washington State.
Thank you, Lynn. A very different environment out here in the state of Washington, not the least of which is that we have some of the lowest cost health care per capita in the country. I think it's been reported we're like the third lowest of the states in the country. And the second is that we have a competitive health insurance environment in the state of Washington that we have 11 insurers in the individual market, 7 of them inside of the exchange. So it's a competitive environment that you don't see replicated in most states, which I think has made a big difference from the standpoint of how we approach the regulation of insurance. Not the least of which was that we wound up being very much surprised when the first filings came into our state in 2013 for the start of the health care reform, the ACA for 14. When we first saw those, we were really caught really quite by surprise the degree to which they had moved toward narrow networks. Narrow networks was a phenomenon that we didn't see in our regulatory environment. It was something that the self-insured market had something like 20% of their plans had narrow networks, but we had not seen it in the fully insured market, much less the individual market, before those filings came in. And in this state, became a challenge because we needed to take a look at what we did to review network of providers per plan. We'd done a pretty good job. We were ahead of what most states had wound up doing at that time. Only about a half dozen states did much, if anything, in the area of network adequacy, and we were doing it before the ACA. But as we looked at what we had in front of us with these narrow networks, we needed to make sure that our rules were ones that we had adopted into regular legal rules as opposed to desk drawer rules that had been much more informal in dealing with insurers than what we'd seen in the past. So we initiated in 2013, immediately at the end of the year when we'd seen these filings as they came in, rule writing that wasn't complete until the start of 2014, but that was the first phase to really legitimize what we'd been doing on a much more tacit basis before the ACA requirements came into place. We had requirements that we then formalized. We had it informally before as to the distance that you'd have to travel to providers, the wait time requirements that you potentially would experience, and we wanted to make sure that you had a sufficient number of providers in the networks, certainly by specialty, and that there wouldn't be any unreasonable delay for you in being able to see a provider. That's what we began to formalize. We had specific standards, actually, for certain types of providers, everything from primary care to hospitals to behavioral medicine to pediatric services. We wanted to make sure that the essential community providers were ones that were appropriately recognized and included in the network, and there was a requirement for them to be included. We updated the provider directory requirements. We'd had a requirement for them to do it before, but this became much more formal then with the rules that we adopted in 14. With the adoption of those 14 in 2014, we could impact then 2015. We were the only state in the nation that had fully comprehensive network requirements in place for 2015. Subsequently, the NAIC has adopted a model that is very close to what we have here in the state of Washington. I still think we probably go a little bit further. Even with that, however, being in place, and it certainly assisted us greatly, we initiated what would be considered the second phase of rule writing that we began in 2015. Almost as soon as we'd finished the rules, we started rule writing once more, and this would add additional requirements now on providers so that they would, on issuers, that they would have to make sure that they supplied sufficient data so that we'd be in a position to develop geo-network reports that actually could be put into maps for each region, and we will be able to analyze just how many providers they were accessing in a particular geographic area, and what kind of services they were accessing. That was the part of our second phase of rule writing then for network adequacy. And again, that was a major step for us, really formalizing that. But again, it works pretty well when you have a competitive environment, because then you're you're pushing back on insurers to the point where they really have to compete on service and quality and outcome, not solely on price. You have a level playing field. These are the requirements that you have to have if you want to be in the Washington market. All issuers, all insurers have to meet the same standard. It's not one where somebody can lowball it and financially benefit from it or undercut what they have in the way of providers. We now have a system where carriers, because of the latter rule writing we went through, where they're actually able to submit online through a portal on our website the information that is truly up to date as to what their network looks like. We all know that networks come and go and can be fairly ephemeral at times, and we want to make sure that they're up to date, so that when you take a look at them, one, we know what that insurer has out there, and it's obviously important then for consumers to know what's an in-network provider and what is not. So this has helped to, in my opinion, push the insurers further away from competing on price because it is a competitive environment with the number of insurers that we have in the market, and now really start to focus on some of these other less tangible perhaps, but at the same time hugely important items, which is service and quality and outcome. And I think those are the ones that help to drive down or hold down the spending. And we certainly saw that for the first couple of years of the Affordable Care Act. Unfortunately, because of this national administration, we've been pushed pretty hard with CSRs being eliminated and removing the individual mandate. We don't have an income tax that we can tie an individual mandate to for a state mandate, so it becomes a lot more challenging. But before those changes started to go into effect, as they have in 2017, we were doing really quite well from the standpoint of helping to hold down the cost of health care here in the state of Washington. So it's a different environment than many other states, if not almost all. But we've also made the tough decisions, and not all states did it, on such things as holding on to legacy policies so that you corrupted your risk pool by allowing these older, inadequate policies. Our individual market before the ACA didn't cover routinely maternity or pharmacy benefits, and so they were really pretty weak and inadequate. You could keep those plans if you chose to allow those to continue, and we didn't in the state of Washington. So that's the big change that we had on that end. We did the Medicaid expansion, which slowly more and more states are adopting, but it had a very positive impact in helping to hold down healthcare spending in the state of Washington. Overall, we continue to do reasonably well. We're challenged because of the changes at the national level, but at the same time, I feel like we're doing better than most states. Thank you, Lynn.
Thank you, Commissioner. And if I can just recall something that you and I were talking about, your authority, which enables you to look at provider contracts, which is a little bit rare among state regulators, we had talked a bit about how that helps address affordability just because you can ensure that if low premiums are associated with high-performing provider networks. And there was an anecdote that you told me about an area of Washington State where somebody had a provider that was charging very high prices. If you remember that anecdote, can you tell the audience what you did in that case?
Yes, and this came at the request of one of our insurers. They requested a modification of our network standards. We refer to them as ADERs, and it involved renal dialysis, and a for-profit renal dialysis provider in that particular geographic area had no competition and was charging phenomenally higher rates than what Medicare would reimburse for the same service. We permitted a modification of network standards for that issuer or insurer that allowed them to pay something like 300 or 400% over Medicare, but not the 1,200% that they were being charged at the present time. So far, that seems to be working well. And again, it's a way of pushing back when you wind up with a company that's in a monopoly position from effectively dictating very high rates with no tangible improvement in quality and outcome.
All right, thank you. Well, we have lots of questions, so let's move to Q&A from the audience. Candy Gallagher, I see you have your hand up. You can ask your question verbally if you like by pressing *6 to unmute. Candy? Try pressing *6 one more time. Okay. Well, interrupt if you're able to unmute. Let me ask some questions that appear in the chat. Commissioners, Jacob asks, how are insurers able to maintain any networks? I think this would actually be for Commissioner Ganim. How are insurers able to maintain networks when hospitals and providers refuse the insurer's requirement to contract at less than or equal to CPI plus 1%?
That is a great question. But we have a state where we have one dominant insurer, and we have other insurers that we have one dominant insurer in the commercial market, we have another dominant insurer in the Medicaid market, and then we have two kind of smaller entries. And the dominant insurers have enough influence over the hospitals so that the hospitals do, in fact, take their contract terms. But we also feel as though there's enough room in our standards so that the hospitals are not suffering. And in fact, as we look to our neighbor in Massachusetts, we unfortunately are in the highest cost area here in terms of our premiums and healthcare costs, this part of the country. So our cap amounted to, as I mentioned, about 2.7% for last year. In Massachusetts, they looked generally at their trends, and they set a cap overall for their healthcare market at about 3% set on their state domestic product. So it doesn't look like we're starving our hospitals, and it looks like they're able to get enough agreeable terms with the insurers to do okay.
I might just, this is Lynn, I might just pile on that in Maryland, they're also able to keep total hospital spending on a per-person basis down to something close to GDP, state GDP, without starving their hospital. So it seems to be possible. I'm going to go on to the next question, which I think is also for Rhode Island. A shy person who goes only by the initial J asks, is there any indication that your standards are spilling over to self-funded employers? Great question.
It is a great question, and thank you. I should have mentioned it. Yes. So our contracts that are entered into by our insurers with our hospitals particularly are the same contracts that then apply to the self-funded plans that those insurers administer. So yes, in fact, that is spilling over. The investments in primary care, that certainly is optional out there in the self-insured world, and I'm not certain to what extent that actually has taken place. But with Blue Cross looking at it and saying, wow, we've got a good return on investment for this, I would think that it is in fact part of the different policies, different contracts that they have for self-insureds.
Okay, great. Tad, maybe you can get our slides back. I'm not sure what happened there. So Candy Gallagher, if you would like to ask a question, try hitting *6 to unmute if you want to verbally ask your question. Okay, no. I also lost the chat. I'm not sure what happened, so I apologize for that. Oh, great. Dina, could the commissioners provide details on what quality improvement information they're looking at during rate review? That sounds like a question for both commissioners. Thank you, Dina.
Well, for the state of Washington, I'd say that that's one where we're principally focused again on what they have for a network, and we're very closely monitoring that network adequacy related issues as opposed to the outcome. I think that what we have in a competitive market where you do not have a dominant insurer in our market, which most states have, is generally one large Blues plan that dominates, as it sounds like it does in Rhode Island, and that's true for many states. Where we have that kind of competition, if you wind up lowballing it from the standpoint of service and quality, you're going to pay a price for it. And you've got to really drive toward developing, albeit narrow networks, but they've got to be high-performing networks that deliver quality care. They can increase they get providers at a lower rate because they essentially guarantee a certain volume, and at the same time, the high-performance providers typically are ones that do a better job, particularly when it comes to certain surgical specialties, which are a big part of the cost. So I think from that standpoint, we've wound up seeing it improve, but we don't have the external monitoring of quality taking place. We leave that to the consumer to make the choice when they do their plan selection.
Great. Well, it sounds like great work going on in Washington. I'm envious. We'll have to continue this conversation, Commissioner. In Rhode Island, I guess it depends on how you define quality improvement. So we have been very fortunate to be part of a national effort, and very possibly Washington State was also, around behavioral health parity. And the focus really was on improving access to behavioral health and ensuring that our insurers are abiding by parity, which is not an easy thing to define nor to regulate. And we were part of this national academy to learn how to do that. So part of our rate review is looking at things like access. So my part of my definition of quality is can you access the services that you need? But in terms of measuring the actual clinical quality, the closest we come is that we require our insurers to have transparency portals that include information on cost and quality, and so the consumers can themselves look at cost and quality indicators and make the determinations where to seek care. The only other place that we're really looking at quality now is relative to our requirements around primary care, that they be in these transformed practices that have certain quality measures, and around accountable care organizations, and again, that they meet certain parameters.
All right, that is wonderful. Would anyone like to ask a question verbally by hitting *6? Otherwise, I've got one for our commissioners. Any verbal questions? All right, well, interrupt at any time. Commissioners, is there any reason why other states should not adopt some of these authorities in order to better protect consumers? Are there conditions on the ground that might suggest you wouldn't want to do either of these approaches? I would just love your thoughts on that, on how we might want to transport this to other states.
Well, I certainly think from the standpoint of if they want to try to provide health care at as reasonable a price and make sure as many of their state citizens are covered, number one is they've got to make sure that they've expanded the Medicaid program. I mean, that's really just fundamental that they've got to do it. Failing to do that has a negative impact on the individual market by virtue of people who would be in the Medicaid program but are oftentimes through third party or other reasons are able to get into the commercial market. They tend to be very high cost individuals, and that hurts you from the standpoint of the risk pool. The other is that if you're still holding on to those legacy policies before the ACA, you've got to get rid of those. Now, the states that didn't expand Medicaid and allowed the legacy policies to continue, some of them are in very desperate situations, generally either because of their legislature or because of their governor, and finding that any ground given toward expansion of Medicaid or constraining the legacy policies is essentially giving in to Obamacare, and I think that's unfortunate because that's really going to come back and bite you if you haven't at least done that. If you do make the appropriate changes, then you have an opportunity to start to focus, depending on your market, on actions that you can see that Rhode Island has taken and the state of Washington has taken, and that really is a way of helping to hold down spending on health care effectively if you wind up doing it the right way.
Thank you. Commissioner Gannon?
Yes, thank you. So I think if you really want to know what some potholes are along the way that we've encountered, I'd say it's political support, and if you are in fact going to take the kind of bold initiative that you're taking in Washington State and that they were taking back in 2013. Certainly the providers were probably very supportive of the activities that they were taking, but I'm certain that it wasn't popular with the insurers. And in our state, some of what we're doing is very popular with the insurers and not with some of the providers. And so you have to make certain that there is support, whether it's from the business community, the consumer advocates, or just that you're making certain that you're listening to stakeholders. And sometimes you can't be as bold as you want to because the political will just isn't there. So that is one of the challenges that we see.
Okay, thank you. So we have a couple questions in chat, and I'm going to break them up. Amy asks, she's asking this of Washington State, do the network standards primarily aim to ensure consumer access, or do you find they lead to improved affordability? That's question one.
I see it moving toward improved affordability, largely because we do have a competitive market, and if you're an insurer in a particular market and you really need to focus on what you're paying for health care. That when it came to selection inside of our health insurance exchange, it was pretty clear that was the major driver from the standpoint of which plan they selected going forward. And the same thing applied even outside of the exchange, but in the individual market. So you have to hold down the price. And the only way you can really hold down the price, in my opinion, is move toward these narrow networks. I find it interesting, the criticism that has been leveled even at before congressional hearings, and I've had the opportunity to participate in several of those over the last couple of years. They push back against the narrow networks as if it's an absolute atrocious action on the part of the insurers. And I said, well, when we started the Affordable Care Act in the first year in 2014, we had both broad and narrow. But you know what? The people chose the narrow ones because they were cheaper. And that was if they wanted a broad network, they had the chance to select it. So we had some providers that really wanted to effectively say everybody had to be in network, And on top of that, we certainly wanted them not to be constrained on rates, just pay bill charges. And that just is not sustainable in any fashion whatsoever. So I think the narrow networks, as long as we monitor them closely and with our online features and looking at the maps that we generate for utilization, and I think we're on top of it to the point where we really make sure that the narrow networks are working. At the same time, I firmly believe that we're also seeing that the quality and outcome is also being enhanced by virtue of the narrow networks, because you have high production providers that are delivering the services, and our experience has been very positive in that regard.
Okay. She's got a few more questions for Washington. How do you ensure the plans are reporting accurately when they give you the data that allows you to do the mapping and do that quality assurance?
We rely on a couple of features. One is we don't have the ability to go out and go to every provider and check and see what they have in the way of a contract. We rely a great deal on the insurer, and we do spot checking. So we do market conduct checks on the part of these insurers to make sure that if they say they have people under contract, they actually do. We've got one insurer right now that, quite frankly, told us one thing and is doing something different. We're working with them to see if we can get that corrected. We will get it corrected, or they won't be offering services. One way or another, we'll get it corrected. But that's the power that we have, is that we will, and we rely a great deal on consumer complaints too that come into our office. I always look at them as being kind of the tip of the iceberg. Most people don't complain, but when they do, take a look at it and see if there isn't a pattern there. If there is, let's go out and double check and see. One, look at what the insurer is claiming, and then number two is, let's see if we can verify that with providers and with them that they actually have the actual contract. We can go to the insurer and say, we want to see your contracts with providers, period. You will supply them, and that's something that's black and white.
Mm-hmm. Yes, which is a great tool to have in your tool set. Amy's final question is kind of channeling the question for Rhode Island earlier. Has this emphasis on network adequacy standards have any spillover into Medicaid or self-insured markets?
You know, it's difficult to assess what it's doing in the self-insured market, just because we don't regulate the self-insured market. So it's more anecdotal than anything else. But when it comes to the Medicaid, I've been really quite surprised with the passage of the Affordable Care Act. We all of a sudden are being forced together in ways we were never before, and I say that because we're the fully insured, and then we have the Medicaid, and all of a sudden we had very little formal contact with the Medicaid program. Now we have routine, regular, scheduled meetings, several a month, where we sit down and kind of work through. And right at the forefront are the issues around networks. What are they requiring for networks as opposed to what we're requiring? And you're starting to see that they're being driven more and more together going forward, and there's more. They're starting to look and feel a great deal more like the commercial market and the Medicaid market. Networks are starting to work and look a lot more the same as opposed to being different. They still are, but it's really started to really show some transition over time. It's an unintended outcome of the Affordable Care Act that has really pushed us to do that. And I think it's appropriate that care for individuals, whether it's in the Medicaid program or in the commercial market, shouldn't be one that has a significant differentiation.
All right, thank you for that. I'm going to issue a final invitation for people in the audience to ask a question verbally by hitting *6 to unmute. I'll give a pause. Okay, hearing none. I have a final question for our commissioners, and while I'm asking it, I'm just going to put up our final slide, which of course thanks everyone, but also advertises next month's webinar, which I'll talk about in a moment. So commissioners, I started this webinar telling the audience of advocates, policymakers, regulators, there's probably some health plans on, about the NAIC's year-long effort to figure out how regulators can address the underlying cost of health care with the idea of bringing premiums down for consumers. Is there any message you want to send out to the audience listening today about how they might help the NAIC in their work, or how they can partner with you to make this really important effort successful?
Well, I would say from the standpoint of my world, it's one of certainly encouraging consumers to file complaints with our office. If they feel like something hasn't worked right for them, contact us. One of the aspects of narrow networks is that there's a higher potential, particularly with certain medical subspecialties such as emergency rooms and anesthesiology, to not have the providers in network and have a surprise bill come through even when you've played by the rules and gone to an in-network overall provider, but find out that some of the providers aren't, and you're getting a secondary bill. I want people to complain to us. We came very, very close in passing a major bill because it's a battle between providers and insurers. Everybody agrees we need to get the consumer out of the equation, but one of the net effects of narrow networks is that it's higher potential when you have narrow networks of having consumers wind up with not having all of their care delivered by in-network and then being surprise billed. So if I had one thing, it is to encourage people to help us be aware of just exactly what's happening out there with the insurers going forward.
All right, thank you. Commissioner Ganim?
Sure. I think that's great, and certainly that kind of input is guides, I think, all of us in our work. But I guess I would move it up a couple of levels too, because and a commissioner mentioned that we have been thrown some curveballs by the federal, some of the federal initiatives that have taken place recently, and those all affect affordability and the work that we do, and it's very difficult when you're running against a tide. So I guess I would encourage anyone particularly that has an ability to communicate with their federal delegation to make certain that they're watching, paying attention to the issues that are important to affordability. We believe that the Affordable Care Act has worked here in Rhode Island. We are very committed to it, and every initiative that degrades our ability to keep people insured is causing rates to go up for everybody else, and it doesn't help us to have these safeties in place for a decreasing population that can afford commercial insurance. So we would encourage that kind of activity as well as the local level activity.
Thank you both, and this would be a good time for a public service announcement. We are funded by the Robert Wood Johnson Foundation, and we're very grateful, but I do want to emphasize to everybody listening today that the Robert Wood Johnson Foundation is a nonpartisan institution that does not, cannot lobby, lest there be any confusion about that. But having provided that disclaimer, I'm really grateful for our speakers today. I think the work that insurance commissioners are doing and this year-long effort by the NAIC is very important, and we look forward to supporting it throughout the year. With that, please join us next month in April. That says April 16th, but I believe the correct date is April 20th, and we're going to be featuring an institution called the Office of the Healthcare Advocate, which is, we're actually going to be featuring this office as it exists in Connecticut, which not only does direct consumer assistance, but it aggregates its experience of working with consumers to provide a powerful consumer voice in other venues, and we're going to be talking about that. So please register and join us on April 20th. And with that, I wish everybody a good day. Thank you for joining us. We hope we see you next month, and a special thank you to our commissioners, Marie Gannon and Mike Kreisler. Bye, everybody.
Thank you.